Okay. Good evening, ladies and gentlemen. Welcome to this session, World Diabetes Forum. I'm Dr. Liu, Fenxuan Liu. I'm the host tonight. And tonight we have a special guest from the United States. He will online contact with us. He is Professor Silvio Inzauqui. Professor Inzauqui, good morning. Can you hear me? I'm
Yes,
Dr. Liu from Taipei. It's my honor, great honor to introduce you, and I will briefly introduction in Mandarin, and then you can start your presentation. 好，各位女士先生，大家晚安。那今天是很荣幸在百灵家的一个筹办之下，我们有一个世界糖尿病的论坛。那相对我们今天讨论的主轴是有关一些糖尿病的治疗，有关SGLT2 它在这个治疗方面的一个指引，包括一些早期运用、早期治疗跟后期的照护，在 CKM 就是我们说的 Cardiac Renal Metabolic 部分，怎么做一个全人化的一个治疗。那我想今天节目也非常的安排的精准，包括说请国外的外宾讲一些早期的预防。那后面的部分讲后期的一些 CKM 的一些预防跟后期的照护。我想今天晚上大家的一个收听的节目，应该是相当的是非常的一个完整。希望大家能够 enjoy 这个一个晚上的夜晚。那首先还是要稍微介绍一下我这边要照顾的一个来宾哈。那 Dr. Silvio Professor Silvio Inzauqui， 他是一个职位是在目前的耶鲁大学的内科教授，同时是耶鲁大学医学院的耶鲁的一个 Medical Center 糖尿病中心的主任跟内分泌中心的主任。他的学历是纽约的 Fordham University， 他同时是哈佛医学院大学毕业。他专精在糖尿病的治疗，他有500多篇的治疗的那个 paper， 包括分布在那个 JCM 跟 JAMA。那他同时也是 ADA、ESD Position Statement 的一些Writing Group 的 Co-Chair。那同时他更是几个大型的 Clinical Trial 的一个 Leader， 包括说我们最熟悉的EMPA-REG 啊。所以我想今天有他的一个全面性的一个对糖尿病的治疗，多半的一些可以及时给我们特别一些世界的一些方面的一些讯息，希望我们在地医疗跟世界能够同步接轨。So, ladies and gentlemen, let me enjoy me together to welcome the Professor Inzauqui.
Well, thank you very much for that very kind introduction, and it's a pleasure to be here this morning here in the United States. I know it's in the evening in Taiwan. And what I was asked to speak about was the role of the SGLT2 inhibitors in the management of type 2 diabetes, but specifically focusing on the early intervention strategies to combat this syndrome of cardio-kidney metabolic diseases that we know is rampant in our populations. There have been estimates that upwards of 14 or 15% of some regions of the United States now have type 2 diabetes. And I know the rates are also increasing in Taiwan. And when you manage patients with type 2 diabetes, as all of you in the audience know, you frequently deal not only with cardiovascular disease, i.e. atherosclerotic cardiovascular disease, but also heart failure and also chronic kidney disease. And these three conditions of the heart, the metabolism, and the kidney very, very often coexist. And we began speaking about what used to be called CRM, or cardiorenal metabolic disease, and more recently CKM, cardio-kidney metabolic disease, basically in response to the enormous database that's emerged over the past 10 years, specifically focusing with the SGLT2 inhibitors, and to some degree more recently with the GLP-1 agonists. So the discovery of these agents led to new perspectives in how we address patients with CKM, CRM, and how we treat them with pharmacological therapy. So these are my disclosures. And the way I've structured my comments over the next 30 minutes or so is first to give you a short background on the SGLT2 inhibitors. These are drugs that have been available, at least in the United States and Europe, since 2013, 2014. I'm not exactly sure when they became available in Taiwan, but I suspect right around that time as well. Then we'll review the cardiovascular benefits of this important drug category. We'll review the renal benefits or the kidney benefits of the SGLT2 inhibitors. We'll talk about the latest treatment guidelines, and I'll focus my comments on the ones that I know best, which is from the American Diabetes Association. And then number 5 will be probably the shortest component of my talk, only because we really don't know a whole lot about how these drugs are working specifically on the kidney and on the heart. We know very much about the metabolic effects, how they induce glucosuria and lead to a reduction in hemoglobin A1C. But after 10 years of evidence-based medicine stemming from the EMPA-REG OUTCOME trial, there is still not agreement on specifically how these drugs reduce the kidney and the cardiac complications of diabetes. So we know that the kidney is a very important organ in type 2 diabetes. One of the reasons is because the kidney is responsible in part for endogenous glucose production. So this is a phrase that encompasses the body's production of new glucose, and that can be obviously from glycogen breakdown or glycogenolysis, and as the kidney is concerned, gluconeogenesis. Now, obviously, most of this occurs in the liver, not the kidney, but there's increasing realization that upwards of 20% of endogenous glucose production actually stems from the kidney. Now, that's not the role of the kidney as it relates to the SGLT2 inhibitors. It's the second aspect, which may be actually more important aspect of the kidney as it relates to glucose. And that is that the glucose is filtered. The plasma glucose is filtered at the level of the glomerulus. And it's in the proximal tubule that the sodium glucose cotransporters have their major activity. And here there are 2 transporters, SGLT1 and SGLT2. And these together reclaim about 100% of the glucose that is filtered. Now, the plasma glucose concentration is equivalent to the glucose concentration in the early glomerular filtrate. So if the patient has a blood glucose, for instance, of 130 milligrams per deciliter, here in the proximal tubule, the concentration is 130 milligrams per deciliter. And without these transporters, that would be an enormous waste of energy. Patients or people would be glucosuric 24 hours per day. They would potentially have, it depends on the degree of glucosuria, of course, but they would have the significant osmotic diuresis, become dehydrated, and significant weight loss. So that wouldn't obviously be good. So these transporters have been placed in the proximal tubule in order to resorb the glucose, such that when they're active, there is essentially 0 glucose in the urine. Now, most of the activity is through SGLT2, whereas SGLT1 is mainly expressed in the GI tract. And there's an interesting SGLT1 and 2 inhibitor called sotagliflozin that may have at least some of this activity in the intestines. Now, the SGLT2 inhibitors have been studied for about 20 years when it became realized that pharmacologically, these transporters could be blocked. And when these transporters are blocked, obviously the glomerular filtrate now continues to contain glucose through the loop of Henle into the distal tubule and into the collecting duct, and carries with it some degree of osmotic diuresis, as well as an increase in sodium concentrations in the urine as well. And that, when we talk about mechanisms, may be at least partially responsible for some of the cardiovascular benefits, specifically the heart failure benefits. Now, in most individuals, when SGLT2 inhibitors are used, the average amount of glucose excretion is about 70 to 80 milligrams per day, and that translates to a kilocalorie loss of about 300 per day, which is substantial. Now, of course, if this were going on forever, patients would lose a lot more weight than we have seen in the SGLT2 inhibitor trials. So there's this interesting compensation for the calorie losses. And actually, it's been demonstrated that when mammals are exposed to SGLT2 inhibitors, their dietary intake actually increases in terms of calories. So as we'll see, the average weight loss with the SGLT2 inhibitors is only about 2 kilograms. And that is consistent from trial to trial. And this really represents the compensatory mechanisms that the body has to preserve body weight. Now, when we look at the kidney specifically, the healthy nephron has a certain maximum glucose reabsorption capacity, which is exceeded at 180 milligrams per deciliter, meaning that if an individual has a blood glucose under 180, all of the glucose that is excreted into the glomerular filtrate is able to be reabsorbed, and urinary glucose will again be zero or very close to zero. It's only when that threshold is exceeded that individuals, and these would be individuals obviously with diabetes, develop glucosuria. Now, in diabetes, it's very interesting that these are studies done by Dr. DeFranzo's group many years ago. It's been demonstrated that the threshold is actually increased to 240 milligrams per deciliter. So one may say that there's not enough glucose being excreted by the diabetic kidney, at least in type 2 diabetes, to compensate for the degree of hyperglycemia. And when we use an SGLT2 inhibitor, that threshold is reduced well under the normal range of 180, all the way down to about 70 milligrams per deciliter or less. So it's very interesting to consider that patients with type 2 diabetes, even when well controlled, continue to have significant glucosuria. In fact, when these drugs are tested in normal volunteers will develop significant glucosuria, even though obviously by definition their plasma glucose concentrations are normal. Now, these are older meta-analyses from about 30 or 35 studies looking at the original SGLT2 inhibitors, including here in green empagliflozin, but also DAPA, CANA, and two flozins, which are actually mainly available, I believe, in Japan, IPRA and lucigliflozin. And we can see that these agents are modestly effective. They're not powerhouse hemoglobin A1C reducers, as we see with some other type 2 diabetes therapeutics. The mean glucose reduction is somewhere around 0.6 to 0.8 percentage points, with a mean reduction of about 0.7. In addition, as I just mentioned, there is this modest reduction in body weight of about 2 kilograms. And also, and this may speak to the increases in sodium excretion, which is probably approximately 80 millimoles per day, a reduction in both systolic, here about 4 millimeters of mercury, as well as diastolic, here about 2 millimeters of mercury reduction. So very early on, the investigators working with this interesting drug category, which had at least at the time, this is in the early 2010s, when the initial phase 3 clinical trials began to be performed specifically with empagliflozin and dapagliflozin, the investigators felt that this may be a medication that could not only reduce hemoglobin A1C, but also potentially have a beneficial effect on cardiovascular outcomes. And this is because, as we'll see later on, there's a constellation of clinical features in patients with type 2 diabetes who begin to initiate therapy with an SGLT2 inhibitor that speaks to a reduction in cardiovascular risk. And this includes the reduction in weight, although obviously it's modest, as well as the small reductions in blood pressure. So when we sized up the SGLT2 inhibitors, and this is now bringing us back to 2015, before the EMPERATE outcome trial was released, the risk to benefit ratio, as we say, looked something like this. And I must say that every type 2 diabetes therapeutics, from sulfonylureas to metformin, the GLP-1 agonists, you can construct a benefit risk analysis, and choosing the right medication for your patient as a clinician, as a physician, is to balance these and obviously to favor more benefit than a risk. But at the time, again, before the clinical trials began to come out, speaking to the enormous benefits from the cardiovascular system and the kidneys perspective, this is the lay of the land, shall we say, for the SGLT2 inhibitors. Again, modest effect on A1C, importantly, low hypoglycemia rates, because even though the renal threshold is under the normal range, under 70 milligrams per deciliter, there are other compensatory mechanisms that the body has that prevents hypoglycemia. Importantly, the early reduction in insulin secretion. We talked about the weight benefit. We talked about the blood pressure benefit. There was an interesting story that emerged at around this time, that when tested in patients with albuminuria, there were prominent reductions of about 50%. So that already interested some of the nephrology-oriented scientists studying this drug class, because we know that other medications that reduce albuminuria have long-term benefits on chronic kidney disease risks, and also some modest benefits on lipids, specifically triglycerides and HDL. On the downside, patients would urinate more frequently. This could be problematic in patients with incontinence, for instance, or men with benign prostatic hypertrophy. Older individuals that have altered thirst signaling could become dehydrated. We realized very early on in the development course of these medications that genital yeast infections were more common, specifically in women and uncircumcised men. The notion of urinary tract infections was a concern initially, but subsequent studies show that the UTI rates are equivalent to placebo. There was this small reduction in GFR, which initially was a concern. Obviously, that's not something you want to induce in patients at risk for chronic kidney disease, but we later learned that that actually could be a marker of the kidney benefit, that this is an offloading of the glomerulus, reduction in intraglomerular pressure, that actually predicts which patients will have reductions in albumin excretion and this modest about 5% drop in GFR, which is also reminiscent, as I mentioned before, of other drug categories, specifically the RAS inhibitors, such as ACE inhibitors and angiotensin receptor blockers, that do both of those things. They decrease intraglomerular pressure, they reduce albuminuria, they have an initial modest drop in GFR associated with their use, but long-term benefits on the kidney function and that estimation of GFR. A slight reduction in LDL, which never panned out to be anything that was significant in terms of cardiovascular risk. Some of the early agents, one that specifically comes to mind is canagliflozin, was associated with an increase in fracture risk in some of the early trials. Did not occur with the other SGLT2 inhibitors. And a story that emerged a bit after 2015, perhaps in 2016, 17, but I included it in this slide because it's important. And this is the risk of euglycemic diabetic ketoacidosis that can be seen in type 2 diabetes, but is mainly seen if the drug is used off-label in type 1 diabetes, which I'm not recommending because of the complexities of the metabolic impact in patients who are extremely insulin deficient that we don't have time to address. So that's the background of the SGLT2 inhibitors, and frankly, they were of some interest because of their mechanism of action, but they did not seem to be, as we say in the US, home run drugs, anything that would necessarily change the landscape of treatment with the recognition that there were some modest improvements in cardiovascular risk. Now, the world in type 2 diabetes changed when we presented the EMPA-REG outcome trial results at the EASD, the European Association for the Study of Diabetes meeting in Stockholm, Sweden, this now in September of 2015. And it's interesting that we'll be celebrating the 10-year anniversary of this landmark trial at the EASD in September of 2025 of this year. And this trial was important because it was the first one that clearly demonstrated that a glucose-lowering medication could have cardiovascular benefits. As most of you in the audience realize, the history of type 2 diabetes clinical trials and cardiovascular events is not a good one, in that there had been investigations dating back to the 1970s trying to demonstrate that what we do as endocrinologists, as internal medicine physicians, to improve the hemoglobin A1C, unfortunately had very, very little impact on reducing the most common complication of diabetes, which is obviously cardiovascular events, specifically myocardial infarction, stroke, and ultimately heart failure. But the EMPA-REG outcome that tested the SGLT2 inhibitor empagliflozin clearly showed that there were pervasive benefits across the cardiovascular system, specifically on the major outcome of these clinical trials, which is 3-point MACE, MACE being major adverse cardiovascular events. That is the trio of non-fatal MI, non-fatal stroke, and cardiovascular mortality. Interestingly, it was the cardiovascular mortality component of the primary outcome in EMPA-REG that was most dramatically reduced at 38%. And finally, as a secondary outcome, we showed a 35% relative risk reduction in heart failure hospitalization. Now, these benefits were on top of standard of care. So the majority of patients were getting their blood pressure controlled, were already on statins. Now, this was simply looking at the addition of empagliflozin to background diabetes therapy versus placebo. Now, EMPA-REG outcome was the first, but certainly not the last. And this is the largest meta-analysis. This is now across all of the SGLT2 inhibitors, cardiovascular and renal outcome trials. The next speaker will be addressing some of the uses of SGLT2 inhibitors in more advanced patients. But I pulled these data from the SMART-C group, their meta-analysis that was recently published in Circulation that demonstrated across these multiple clinical trials, including many with empagliflozin, that there is a nearly 10% reduction in major adverse cardiovascular events, or I should say the relative risk of those events. Absolute risk reductions are more modest, of course. For the cardiovascular mortality component of MACE, we see a pooled estimate of a 14% relative risk reduction. For myocardial infarction, non-significant 5%, and no effect on stroke. So most of the MACE benefit is actually driven by cardiovascular mortality, which is, I would propose, the most important component of MACE. Now, I spoke briefly about the 35% relative risk reduction for heart failure hospitalizations. I can't tell you how important this finding was, even though it wasn't the primary endpoint of EMPA-REG outcome. I'm not sure how it is in Taiwan, but in the United States, if you look at an older population, so we sometimes focus on Medicare being the health insurance for individuals in the US over age 65. If you look at the reasons for hospitalizations in type 2 diabetes with Medicare insurance, year over year, the most common reason is heart failure, whether it's heart failure with reduced or preserved ejection fraction, as we call them HFrEF and HFpEF. These are often studied in these epidemiological analyses, and as a group, the most common reason for Medicare hospitalizations, perhaps with the exception of 2020, 2021, because of the COVID-19 pandemic. But anything that we can do to reduce those hospitalizations has an enormous impact on the future morbidity and mortality in that population, but also importantly on healthcare costs. So these are now 3 of the original CV outcome trials in diabetes. So we're not looking at the other studies that we showed in the previous slide, the heart failure studies and the CKD studies. We're focusing just on the type 2 diabetes studies. And this is with EMPA in EMPA-REG OUTCOME, CANA with CANVAS, and DAPA with DECLARE TIMI 58. And you can see that there is a consistent reduction in patients with heart failure and without heart failure. So let's focus in on just the heart failure hospitalization outcome and remove CV death. This is just preventing heart failure hospitalizations. And look at the pooled estimate for the effect across these 3 SGLT2 inhibitors in patients here in the top 3 bars who have a prior history of heart failure, and here at the bottom, those without a prior history of heart failure. And you can see that the hazard ratio is nearly identical. This is quite striking. What it means is that if you have heart failure at baseline and diabetes, an SGLT2 inhibitor will help to prevent a readmission for heart failure. But if you don't have heart failure, now obviously patients with type 2 diabetes are often at risk for heart failure hospitalizations because of the diabetes and also because of other risk factors for heart failure, including age, as well as hypertension, and also chronic kidney disease. This means that for the first time, a drug could prevent the new diagnosis of heart failure. And I think that's very, very important information for our patients and speaks to the potential for the earlier use of these medications, even in patients without heart failure. Now, the next speaker will dig into the role of the SGLT2 inhibitors in more advanced patients, looking specifically on chronic kidney disease, many of whom have heart failure. And so I just wanted to touch very briefly on the heart failure trials that stemmed from the very provocative discovery from the diabetes clinical trials that these drugs could not only prevent heart failure, but also prevent the worsening of established heart failure. So the cardiology community, specifically the heart failure community, became very interested in this drug category because of those data that I showed you on the previous slide, and began to put together clinical trials focusing on both HFrEF as well as HFpEF that soon followed, focusing on the primary outcome of heart failure hospitalization, or which an acronym of HHF, as well as cardiovascular death. And you can see that across the board, irrespective of the type of SGLT2 or the situation with sotagliflozin, the SGLT1/2 inhibitor, there was a robust effect on the primary outcome, mean reduction of 23%. And very interestingly, just as we saw with the diabetes trials, there was no heterogeneity between the response in those patients with or without diabetes, meaning that the effect of the SGLT2 inhibitor likely had nothing to do with the glucose lowering effect, because in these trials, 50% or more did not even have diabetes. So let's switch now to the renal benefits of the SGLT2 inhibitors. This also, I must say, stemmed from the EMPA-REG OUTCOME trial. This was a secondary outcome. The primary, as I mentioned before, was 3-point MACE. The outcome was worsening of nephropathy, or the progression of chronic kidney disease. Now, the mean GFR, I should say, in EMPA-REG OUTCOME was in the 70s. So this was not a CKD population, but there were patients who had reduced renal function. Across the board, there was a 39% reduction in the development of a renal event, which included the development of sustained macroalbuminuria, the doubling of serum creatinine, the development of end-stage renal disease, etc. So a very, very prominent fact that sparked a lot of interest in the nephrology community, just as it did in the heart failure community, about using drugs like empagliflozin to reduce the progression of CKD. This is a meta-analysis across 5 of the original diabetes CV outcome trials, showing a consistent effect here of 38% relative risk reduction in the renal composite, which defined progression of CKD as earlier. And there was this interesting observation, as I mentioned before, of this initial dip in the GFR, about 5 percentage points, subsequent stabilization, whereas in the placebo group, there was this slow, inexorable decline in renal function, such that at the end of the trial, despite the initial dip, you're better off if you were on the SGLT2 inhibitor than on placebo. And other trials have shown very, very similar effects, although perhaps not as demonstrable as we saw in EMPA-REG outcome. So this is the meta-analysis that I like, because it pooled data from 4 diabetes CV outcome trials looking at the progression of CKD. And one of those trials was actually a kidney outcome trial as well, known as CREDENCE, using canagliflozin, focusing on diabetic kidney disease. And here the patients are distinguished by their baseline GFR, whether it's totally normal at greater than 90s, minimally reduced at 60 to 90, mild to moderate reductions 45 to 60, or more severely reduced at less than 45. And you can see, and just look at the relative risk ratios here, you can see that across these multiple categories of GFR, there is significant benefit. Actually, visually, it seems that there's more benefit in patients who have the best GFR. Obviously, the event numbers in these patients are very, very, very small, pointed to by the very large 95% confidence intervals. But the main message of the slide is that in early diabetes, or shall we say diabetes associated with relatively normal renal function, there continues to be this very prominent benefit of decreasing the progression of CKD, and we'll see some more data later on with an SGLT2 inhibitor. And just like the nephrology, the cardiac community began to compile clinical trials in the heart failure space, so did the nephrologists. And again, Dr. Hong in the next talk will address this in greater detail. But as a sneak peek, CREDENCE, again, a DKD study, 30% risk reduction, and the 2 CKD trials that included a lot of people without diabetes, EMPA kidney using empagliflozin and DAPA CKD using dapagliflozin, you can see very prominent reductions in the progression of chronic kidney disease. So we know that the benefits of the SGLT2 inhibitors now span across the CKM portfolio of diabetes, cardiac disease, specifically heart failure, as well as chronic kidney disease. This is now the largest meta-analysis, also from the SMART-C collaboration, recently published, that demonstrated for CKD progression, whether you did or did not have diabetes, there is no heterogeneity in that effect. And even for acute kidney injury, which was initially a concern with the SGLT2 inhibitors, there appears to be no significant heterogeneity. So both diabetic and non-diabetic patients benefit. This, as you probably know, is the KDIGO heat map that distinguishes patients based on their GFR here on the left, and at the top, also based on their albuminuria. And the goal in the treatment of diabetes is to keep people in the upper left-hand corner of this chart and try to prevent their progression to the lower right-hand corner of the KDIGO heat map. And this is actually what we showed in a recent publication using data from the EMPA-REG outcome trial. This is now the progression across the KDIGO heat map trying to prevent this progression from the upper left to the lower right, and it is less likely to do so if you're taking empagliflozin. You can see that the rates are much higher for this progression if you're on placebo, empagliflozin decreasing this by 30%. The opposite is also true, and this is mainly from the albuminuria component, that if you're trying to get people to improve their KDIGO risk score, this is more likely to occur, 56% more likely to occur if you're randomized to empagliflozin. So quickly, and we're running out of time, we have just a few minutes to review the treatment guidelines. These are the older guidelines that I was a member of the committee for the writing group of back in 2012 and 2015. Here were the recommendations of the ADA as well as the EASD, is to start everybody on metformin so long as there was no contraindications. If the A1C was not controlled, to add a second drug, such as an SU, a TZD, a DPP4, SGLT2, GLP-1, or basal insulin. If the diabetes was still not adequately controlled based on A1C, to add a third drug, and ultimately, if you needed beyond 3 drugs, to consider combination injectable therapy. This was a very glucose-centric set of guidelines, focused primarily on A1C, and this is because there were no comparative efficacy data at the time looking for important cardiovascular and kidney outcomes. We were strictly focused on the hemoglobin A1C. And we know that we've talked about some of the SGLT2 inhibitor discoveries over the past 10 years, but of the 7 major drug categories that are used throughout most of the world, we know that each of them has a specific beneficial effect on a variety of factors, specific risks and negative effects. But if we focused on the question of which drug has cardiovascular benefit, what we find is the SGLT2 inhibitors have not only that MACE benefit, but also the heart failure benefit. And if we look across the spectrum of these 7 drugs, most are neutral, including SUs and insulin, as well as the DPP4 inhibitors, no specific benefit on the cardiovascular system, perhaps a benefit with metformin, but the studies are small and old with very low event rates, so we don't have a robust data set. The TZDs are complex medications. They have an anti-atherosclerotic effect, but at higher doses can actually increase heart failure. So it's a complicated discussion. And obviously, over the past 8 to 10 years, we know extensive information from not only SGLT2s, but also the GLP-1s, which have an atherosclerotic benefit as well, and probably a HFpEF benefit in those patients with preserved ejection fraction heart failure. So the newer guidelines from the ADA are really focused on the baseline comorbidities in patients, meaning the patients who have atherosclerotic cardiovascular disease, who have heart failure, or who have chronic kidney disease. And briefly, if you have ASCVD, heart failure, or CKD, then the SGLT2 inhibitors are prominently displayed on this algorithm from the ADA to be used, and the GLP-1s can also be used, obviously, with ASCVD, and if you can't use the SGLT2 inhibitor, the GLP-1s can also be used with CKD. The data set for the heart failure patients is not as convincing yet with the GLP-1s, but again, in heart failure, there may be a significant benefit as well. And then once you've addressed the question of what's their comorbidities, then you can use a variety of medications being more glucose-centric, trying to get the hemoglobin A1C, and you can see that the SGLT2s are used on the right side of the algorithm as well. We know that combination therapy works not only from an A1C reducing standpoint, but also on the basis of the reduction in the variety of complications of the cardiovascular system. So this is a meta-analysis showing that in the SGLT2 inhibitor trials, there was no heterogeneity in those patients with or without a GLP-1 agonist at baseline, suggesting that these drugs might have benefit. I'm running out of time, so I'll just say one word about the mechanisms, is that we don't know yet exactly how these drugs affect the kidney and the heart. There are many theories in terms of reductions in preload, reductions in intraglomerular pressure, but I think there's a lot of interest in specifically mechanistically how these medications are exerting their effect. We have shown a reduction in cardiovascular events may be linked to the increases in hematocrit. We don't know precisely what that means. It could be related to hemoconcentration or an erythropoietin effect on red cell production, but I think is an interesting evolving story. So these drugs are in widespread use in type 2 diabetes. They lower blood pressure and weight in addition to A1C. They have some side effects, as we've discussed. The EMPEROR outcome trial was the first of the SGLT2 trials to show cardiovascular as well as kidney benefits, and these benefits have now been extended to heart failure and CKD populations, and international guidelines now endorse their use in those with ASCVD, heart failure, and CKD. I was asked to put together a case, and I'll go through this very, very quickly, perhaps for discussion, but this is a typical patient I would propose in your practice, certainly in our practice here in the United States. A 64-year-old woman, type 2 diabetes for 6 years, currently being treated with basal insulin, with metformin, the DPP-4 inhibitor sitagliptin, as well as a sulfonylurea glimepiride. And her A1C was 7.2%, and she has occasional hypoglycemic episodes, none being severe. Hypertension and dyslipidemia over the same course of time, but has not yet experienced any cardiovascular events. She has an echo in her chart because of previous history of palpitations and PVCs, and she has left ventricular hypertrophy and some suggestion of diastolic dysfunction based on sonographic parameters. She comes routinely back to the office to address her diabetes control. She feels pretty good. She has a little edema at the end of the day, and this is her past history, very typical of a patient with diabetes, and you can see her medication list as we discussed. Her weight is increased, her BMI is 32, her blood pressure is reasonably well controlled, although not ideally, and her exam is not that remarkable, perhaps a little bit of ankle edema and maybe some neuropathy. And here are her laboratory data. Her A1C is 7.1, her fasting plasma glucose is 132. Her kidney function is reasonably preserved, but she does have microalbuminuria. Her lipids are reasonably well controlled, except for increases in triglycerides. And interestingly, an NT-proBNP was checked, and it's minimally elevated. And her electrocardiogram, sorry for the typo there, shows LVH, but no ischemic changes. So the question for us, and perhaps for the panel, would be, would you, and perhaps how would you adjust her glucose lowering medication? Again, her hemoglobin A1C being 7.1, microalbuminuric with normal kidney function, no history of CVD, but some suggestion, at least on echo, that she may be at future risk of heart failure, and that is endorsed by the minimally high NT-proBNP. So would you get rid of the sulfonylurea and just adjust her glargine to get the hemoglobin A1C down lower? Would you get rid of the DPP-4 inhibitor and put her on a GLP-1 agonist because of her obesity? Would you stop the sulfonylurea and add an SGLT2 inhibitor? Or would you be very comprehensive and stop all therapies and begin an SGLT2 inhibitor and a GLP-1 agonist, because both of those have cardiovascular and perhaps kidney benefits as well? So, Dr. Liu, I will hand this back to you, and perhaps you can lead us in this discussion over the next 5 or 10 minutes.
OK， 那它不是要放着吗 Okay. Thank you, Professor Inzuki, for your nice talk and comprehensive speech. The question for the discussion: how would you adjust a glucose-lowering medicine? Is there any audience prefers which one you choose? Does anyone choose one? A, B, C? C have three answer. Any D? Much more? Okay. The audience choose the D rather than C. How about your opinion?
Yeah, that's interesting. That's in the U.S. I'm not familiar with the Taiwanese healthcare system. In the U.S., this would be a very expensive undertaking because the SGLT2 inhibitors are now over $400 per month, and the GLP-1 agonists are over $1,000 per month. So that decision, at least in the U.S., would cost someone. Obviously, people have insurance, and the cost may be negotiated beyond that point with the pharmaceutical companies and the insurer, but at face value, the cost of that decision would be approximately $1,500 US dollars per month, which would be an extraordinary cost for managing type 2 diabetes. Again, in a patient population, this lady does not have established CVD, but it would have the benefits, obviously, of getting her to lose weight. It would probably get rid of her microalbuminuria and maybe preserve renal function and decrease heart failure. I think that the only concern I would raise with B is that stopping everything, somebody on a reasonable dose of insulin, she may not be able to control herself simply with the SGLT2 or the GLP-1. So once somebody is on insulin, that speaks to a greater degree of beta cell dysfunction. We've all seen patients go on GLP-1s and completely be able to stop their insulin, but I would be a little bit cautious not to be overly enthusiastic that this woman would be able to stop all of her medications. She's on a substantial amount of insulin and three other agents, actually. So whether you can control her A1C with an SGLT2 or a GLP-1 is unknown, possible, but unknown.
Okay, thank you. Is any question from the audience? Yes, please.
请问一下，那个肾功能如果在stage 3或4，但它却没有蛋白尿，因为我临床上有些病人他其实没有蛋白尿，这个 SGLT2 还会有帮助吗？
And the question translated to English is, how about you use the medication in the diabetic patient in renal function stage 3 and 4, but without proteinuria? Can we use the SGLT2 for the patient?
Yes, I thank you for that question. I think it'd be interesting Dr. Hong's opinion on this. He's the nephrologist, but when we look at the CKD trials that obviously recruited an enriched population with decreased GFR, what we see is that there is a reduction in the progression of CKD, as I showed before, although that was using some of the diabetes CV outcome trials, not necessarily with CKD. What we saw before is that across the categories of GFR, there appears to be consistent benefit. So you don't have to have a GFR in a low range to benefit from these medications. The other observation from these trials is that you don't have to have albuminuria to benefit from these medications. So your question specifically is, well, I have a patient who has diabetic kidney disease or non-diabetic kidney disease, maybe some history of glomerulonephritis or acute interstitial nephritis that has not recovered. What is the evidence that that person who has advanced CKD based on GFR criteria, but no albuminuria, so there's not much of a, shall we say, a glomerular abnormality, what is the likelihood that that patient will benefit from the SGLT2 inhibitor? And the answer is that the presence or absence of albuminuria is not a risk modifier for that beneficial effect of the SGLT2 inhibitor. Said another way, you don't have to have albuminuria to experience the benefit of the SGLT2 inhibitors. I actually feel that the microalbuminuria is a marker of patients that may benefit to a greater degree in our practices, particularly those with early stage CKD, but that's not supported by the evidence from the clinical trials.
Okay, thank you for your answer. I have another question from the audience. Did you use the SGLT2 in the low-risk diabetic patient just for the early prevention? Can you give your comment?
Yeah, I think that the study that we showed looking at the KDIGO heat maps, I think speaks to this, that when we pooled all the data looking at everyone who had progression of CKD, so movement toward the lower right of that chart, or even more encouragingly, moving up to lesser forms of CKD, so moving up to the upper left of the chart. I think the SGLT2 inhibitor, specifically in that trial, empagliflozin, does both. So it increases the likelihood of not progressing and increases the likelihood of regressing the CKD. And I think that can be seen both in patients with advanced CKD, moderate CKD, or no CKD at all. I personally feel that the SGLT2 inhibitor should be used in virtually all patients with diabetes because, number one, they have a beneficial effect on hemoglobin A1C, blood pressure, and body weight. And number two, the long-term impact of slowing that progression should have significant benefits years, decades down the road in patients with diabetes. So why wouldn't you use a medication that has specific CKD benefits as opposed to sulfonylurea, for instance, or a DPP-4 inhibitor, which are just as good, if not better, glucose-lowering agents, particularly speaking to the SUs, but don't have any specific targeted benefit on the kidney. That would be my view.
Okay, thank you for your comment. Another question is from the audience also. When considering GLP-1I and SGLT2I in early KKM syndrome, do you have a preferred sequence or combination strategy based on the current evidence?
Not really. I think both are beneficial. I do favor the SGLT2s if there's heart failure or increased risk of heart failure. I do favor the SGLT2s in those patients with renal disease. I think the data is much stronger with the SGLT2s versus the GLP-1s. If somebody has normal LV function and no CKD, but has ASCVD, I think the data are a little stronger in contrast with the GLP-1 agonists. So maybe more toward the GLP-1s for ASCVD, more for the SGLT2s in heart failure or CKD. But ultimately, patients will require multiple therapies. And as the audience picked D here, the combination therapy, I think that probably is the wisest approach because the mechanisms are completely different. And as I showed you on that combination therapy slide, they're probably complementary, maybe not synergistic, but they're probably complementary, meaning that they have individual effects, and those effects are demonstrated in combination as well as with monotherapy. The concern, and I'm speaking from an American perspective, the concern is the cost. Because if you put every diabetic patient on SGLT2s or GLP-1s, you would bankrupt the healthcare system here in the US. So I think some conservatism in this choice, particularly in early onset patients, should be considered choosing one of these drugs and maybe adding the second if there is progression of the diabetes.
Okay.
Or new indications.
Okay, thank you. Is there any question from our audience? Okay, last question.
我有一个 DN 的病人，他其实有一点点 heart failure 啦。那我也有给他用那个 Forxiga， 就是 SGLT2 inhibitor， 但是他真的是会 UTI， 请问这有什么好方法吗？可是他又真的蛮需要那个 SGLT2， 我觉得。
How to control the urinary tract infection when using the SGLT2?
If I understand, I think that the UTI risk is low and probably, at least according to the clinical trials, probably not different from placebo. So there's a theoretical risk, of course, of a urinary tract infection, but most of the infections that we see with SGLT2s are genitourinary. In other words, more on the genital side than the urinary side, if I can say that. So they're basically candida vaginitis or candida balanitis, and those can be easily treated typically with topicals, occasionally with oral agents. I do think that there are some patients that have recurrent yeast infections, and those you might need to consider stopping the medication. Although sometimes I try every other day dosing, and that seems to work in some patients. I think you get consistent glucosuria, and for some reason, if you give them a little bit of time off, the infection doesn't get a chance to take hold. But that's just anecdotal. Sometimes you do need to stop the medication if you have a persistent problem. If you have a urinary tract infection, I would treat that. If they get a second or a third, again, just like the genital yeast infections, I would have to reconsider the option. Obviously, urinary tract infections in some patients can be serious. And if they do get urosepsis or pyelonephritis, I think that makes you even more concerned. But the data would not speak to an increase in urinary tract infections. But obviously, as clinicians, we have to make individual decisions. I would say that I do tend to avoid them in patients that are very high risk for infections. So if you have somebody with an indwelling catheter in the bladder, if you have somebody who has a uteral stent, I think we need to be a little bit cautious in that individual because they may be at higher risk of those types of infections.
Okay, thank you for your answering. And due to the time limit, I must close this session. Thank you, Professor Inzuki.
Okay.
Thank you once again
Thank you.
for your valuable contribution. Hope next time you can come to Taipei again. Thank you.
Thank you for having me. Appreciate it.
Thank
Bye-bye.
you. Thank you. Bye-bye. Thank you.
.各位医师大家好，我是台北荣总新陈代谢科的陈涵许医师。那今天很荣幸来介绍洪思群主任哦。那洪思群主任他现在是心电慈济内科部主任，然后兼肾脏科主任。那洪主任哦，他是台北医学大学毕业，那曾经在我记得他有在星光医院当过克拉克哦，然后在我们台北荣总当intern 住院医师。我跟他算蛮熟的啦吼。他在2015年有一篇 paper 哦，登在 Lancet Diabetes and Endocrinology 那篇 paper 那个 journal 好像那一年才上，我才知道那篇 paper。他在探讨 metformin 在 advanced kidney disease 的病人身上，然后对 CV outcome 仍然有好处哦。那一篇 paper 我拜读了好几次，也跟洪医师讨论过。他在这几年来虽然离开了台北荣总，还是跟我们有密切的接触啦哈。那他今天呢跟大家介绍的是在治疗 difficult case， 然后 with cardiovascular kidney metabolic syndrome 主要是 focus 在 CKM stage 3到4的地方。那我们以热烈的掌声来欢迎洪思群主任。
好，那谢谢陈教授的介绍。好，各位新陈代谢科、肾脏科、心脏科的先进前辈，大家晚安。那我今天的任务哈，那题目是说要来讲这些比较难搞的啦哈，就是 CKM 比较后期这些 advanced CKD 的病人。 好，那其实这个是 AHA 它对这个 CKM 的一个分歧哈。那其实我们今天要讲的 Stage 3跟 Stage 4，那从心脏科医生的观点来讲哈 ，Stage 3它是 subclinical 的 CVD， 那如果到 Stage 4的话呢，它就是一个 clinical 的 CVD。好，那我们晓得就是说 subclinical 的 CVD 呢，那你当然可以把它分成是 subclinical的 ASCVD 跟 subclinical 的 heart failure。那如果是 subclinical ASCVD， 我们怎么样去做评估？好，那很简单，就做 EBCT 嘛，哈，看它的这个钙化的分数。那如果是 subclinical 的 heart failure 呢？哦，你可以做心脏超音波哈，但是如果病人是 PEF 的话，这个难度就很高哈。那另外我晓得新陈代谢科他们可以在比较早期就去做 NT-proBNP 的一个 screening。那可是我们要晓得就是说呢，这个 NT-proBNP 在这个 heart failure 的病人哈，当然如果肾功能正常人 ESC 的切点应该是125嘛哈。可是你如果碰到一个 CKD 的病人哈，这是我们自己 CKD cohort 的一个 data， 大概随着 CKD stage 越后期，这 NT-proBNP 就会越高了哈。那你甚至可以看到，就是说在第5期 CKD 的病人哈，他 NT-proBNP 甚至可以上万哦哈。那但是他也没有办法告诉我们说，这个病人他到底有没有这个 subclinical 的心衰竭哈。那所以其实，在 CKD 的这个框架下面哈，那很多事情都会改变。好，那如果是 Stage 3的这个 CKD 哈，那事实上对应 CKM 对应到这个 CKD， 那我们可以看就是这个 risk equivalent 哈，它就是一个 very high risk CKD 哈。那另外呢，就 CVD 来讲呢，那这一群这个 Stage 4、Stage 5 CKD 的病人哈，那他也是非常高的 CVD 的一个 risk。好，那所以呢，在这个 AHA 呢，它有发展出一个新的一个这个 risk calculator 哈，叫 Prevent。那这个 Prevent 呢，我不知道大家有没有用过了哈。有一次我尝试去用，那发现说，很像不太好用了哈。那第一个就是说呢，它导入了这个 UAC 啊，那你可以把它点开哈，你可以把实际病人 UAC 啊这个 MGG 的这个 data 把它输进去，好，那就可以这个把 UAC 啊当成是这个 risk calculator 的一个选项。但另外比较特别是 eGFR 了哈，它这 eGFR 它只能输入第4期以上的这个数字哈，所以表示原始的这个 development cohort 呢，他的病人他就是没有第5期的病人哈。那所以如果我们第5期的病人甚至洗肾的病人呢，你大概就没有办法用这个 Prevent 的这个 online calculator。不过我想它还是一个进步了哈，至少你的病人哈，如果是这个第4期以上 CKD 哈，那你也可以把它的 eGFR 跟 UAC 啊把它输入进来。那不过这个 Prevent 的这个 calculator 呢，它比较适用在这个 primary prevention 的 cohort， 也就是说你的病人如果原本就有 ASCVD 哈，你用这个 calculator 可能会低估这些病人的风险哈，那这个是我们要注意的地方。那另外就是说呢，在这个第3期的 subclinical 的 CVD， 在 CKM 呢，他说这个级别哈对应到 CKD 哈，就是我们所谓的这个非常高风险的这个 CKD 哈，它包含了这个Stage 4跟5了哈，就是你从 eGFR 来看小于30的病人哈，那当然你可以看这个 KDIGO 的这个CKD risk 的 heat map， 那主要就是这个橘色哈跟这个红色的区域哈，就是不管是 eGFR 比较低哈，还是 UACR 比较高的这群病人呢，那这个都叫做 high risk 的这个 CKD 哈。那这个 high risk CKD 当然表示它比较容易进展到透析哈。另外呢，这群病人他的这个 ASCVD 跟心衰风险呢也比较高。那我们从过去的这个临床试验呢，最早是在 Credence 哈，那这个完全都是这个糖尿病生病变哈，有比较大量尿蛋白的病人。那接着呢到 DAPA CKD。但是它涵盖的病人哈，其实都没有很广了哈。那涵盖病人最广的呢，还是 EMPA-KIDNEY 哈。那在 EMPA-KIDNEY 呢，它收录了这个eGFR在20以上哈，从这个 normal 哈到这个 micro 到 macrobilirubin 病人呢，它都有收录哈。那所以呢，我想这个 EMPA-KIDNEY 的病人哈，是我们在处方这个 CKD 病人 SGLT2 inhibitor 好一个比较好的一个参考的一个 try。 那在早期呢 ，Empakini 它第一版的这个 data 发表的时候呢，我们可以看到这群病人哈，即便它包含了 normal 到 micro 到 macroalbuminuria 的病人，那它的这个 kidney disease progression 的 hazard 呢，大概下降了这个29%哈，那这是有显著的一个统计的意义。那但是呢，当时我们可以看到 CB death 的 data 哈，似乎就没有这么样子的显著了哈，那所以对比呢，其实之前发表的这个 Credence 哈，它事实上是有 CBDS 的一个好处哈，那甚至在这个DAPA CKD 呢，你也可以看到哈，这个药物在 CKD 的病人对 all cause mortality 的一个帮忙。那但是在 Empakini 呢，除了CBDS 呢一开始没有看到好处之外呢，那刚才也有前辈就是有问这个问题哈，那到底一个 CKD 的病人哈没有尿蛋白的话，到底可不可以用这个药了哈？那事实上，在一开始 Empakini 的 data 也跟我们讲说，我们可以去看次组分析呢，这个 normal 哈，甚至是 microalbuminuria 病人跟这个 macro 的病人比起来哈，那它的这个效果呢 ，people interaction 是小于0.05了哈，表示这个 micro 到这个甚至 normal albuminuria 这群尿蛋白比较低的病人。在这个 Empakini 2年的这个追踪呢，你是没有办法看到它对 outcome 改善的一个好处相对于 macroalbuminuria 的病人。好，那为什么会有这个现象主要是这个 Empakini 的病人相对于 Credence 跟 DAPA 呢，它是比较低风险的了你可以看这个 placebo 的 group，eGFR 的这个 decline 呢，它比 Credence 一年4.6那 DAPA 的3.6，它一年大概是只有2.8。那你也可以看到 Empakini try 的这个 population 它的这个每年死亡的这个风险事实上它也是最低的。所以呢，这个 Empakini 相对于其他2个这个 CKD SGLT2 inhibitor try 呢，病人的 CKD progression 跟死亡的风险都比较低，所以也许这个临床试验需要比较长时间的观察你才可以看到这个药物的好处。好，所以呢，这 Empakini 呢，在今年就发表了这个 study 呢，在 post try 之后2年的追踪。那这个研究呢，在这个第一版它这个 median follow up 2年之后又继续追踪了2年那在这个临床试验停止的这个2年的时候呢，分别在这个 placebo arm 跟原本的这个 EMPA 的 arm 呢，各有40% 的病人继续在用 SGLT2 inhibitor。但是你可以看到，就是说呢，即便在2年追踪这个蓝色跟黄色的曲线呢，它使用 SGLT2 inhibitor 的比例是一样的各有40%，但是你会看到2条线它还是持续在分开这表示呢，早期使用 EMPA 呢有它所谓的 legacy effect所以这个药物呢，你早期使用，即便停药之后那这原本在分派在不同2组的病人，即便现在使用的 SGLT2 inhibitor 的比例都一样但是呢，早期使用 EMPA 的好处呢，还是可以看到。那另外我们可以看到，就是说呢，在 Empakini post-trial follow-up 的这个 CBDS 呢，你在经过4年的追踪2年加 post-trial 2年呢，你就会看到它有25% 明显的这个 CBDS 下降的一个好处。那甚至呢，在原始呢，本来看到 normal 到 microalbuminuria 病人，它相对 macro 的这个好处比较小那事实上呢，在 post-trial follow-up 你就会看到这3组呢，它的 P4 interaction 呢是超过0.05，也就是说呢，这个药物你比较早期的去使用，追踪比较长的时间事实上呢，对即便没有尿蛋白的病人呢，它一样有 for 这个 CKD progression 跟 CBDS 的一个好处。好，那如果到第5期的这个慢性肾脏病的病人呢，在去年美国肾脏医学会高医呢，他们发表了一个这个第5期的一个 RCT， 那他们收录的病人呢，eGFR 更低它低到10所以他们收录了一群这个大于20岁那也有糖尿病，也有非糖尿病的病人他eGFR呢是介于10到20涵盖第4跟第5期 CKD 的病人。那他把这群病人呢用2:1的这个分配那有2/3分配到这个 DAPA那另外呢有这个1/3呢就是做这个 usual 的一个 care 那我觉得这临床是很可惜，它并不是一个 placebo control 的一个 try。那不过呢，在追踪超过这个1年以上的时间我们可以看到它的 primary outcome 对不起，它 它的 primary outcome 呢是这个eGFR decline 的这个速度哈，大概两组呢差了1.2了哈，这个是有临床上有显著的一个差异。那另外呢，你也是可以看到，就是在 secondary 的一些 hard outcome 包括这 renal 的 composite endpoint， 这个跟之前这个 CKD 的这个临床试验一样哈，我们定义就是用这个eGFR 衰退超过50%哈，那进入 ESKD 跟肾阴性、心因性的死亡，你会看到风险甚至比较早期的这个 CKD 哈，甚至没有 CKD 病人的 try 呢，它的这个风险呢下降的更多哈。那另外，如果是看包含 AKI 心衰竭哈，还是传统的这个 CB 的这个 3-point MACE 呢，那它的这个哈达下降哈，大概也都有到50%。好，那所以呢，我想现在在这个SGLT2 治疗的观念哈，不管从很早期没有 CKD 没有尿蛋白哈，那就是纯粹是做这 ASCVD 的这个 secondary prevention 哈，像在 EMPA-REG， 还是在比较后期的 CKD， 不管已经进入到第5期的 CKD， 有没有尿蛋白哈？那我想比较晚期的病人了哈，你有用总比没有用好。好，那所以呢，在这个SGLT2 inhibitor 的一个使用哈，那可能跟早期我们使用 statin 的观念一样了哈，就是 the early the better，the longer the better。好，那所以就像刚才前一位演讲者一样哈，大概你前期的病人哈，你都可以考虑使用这个 SGLT2 inhibitor 哈，来作为这个新生的一个保护。好，那我接下来有几个案例哈，有一个64岁的这个女性 DKD， 那转介到肾脏科的门诊哈，那她当时使用的这个血压药物当然有包含 ARB 哈，那另外她还有这个 Actos 跟美福明。那比较特别是，他那时候肾功能已经不好了哈，理论上应该美福明应该这时候是要停用的。那当时因为病人有比较大量的 proteinuria， 那血钾也比较高哈，那似乎糖化血色素也高了哈。那时候到门诊的时候，我们看到第一次的 UPCR 是 8.56 哈，那时候的 eGFR 已经小于25了啦。那因为在2023年的时候，这个 McKinney刚发表了哈，那所以我们大概就在原来的处方，我们先把 Actos 美福明先停掉，那把它转换成这个 Jardiance， 你大概就会看到说它的尿蛋白呢，在2周哈就有非常明显的一个下降。这个之前所有的 SGLT2 inhibitor 的这个研究在 CKD 哈，这个尿蛋白大概2周就会下降了哈。那不过你也可以看到，就是说它在这个3个月呢，看到这个 eGFR 一个比较明显的一个低频哈，那时候已经降到这个16。那大概我们一般容忍的降幅大概就是30% 了哈，那所以我们就还是很勇敢的就继续用。那后来呢，这个eGFR也有回升的一个现象，那尿蛋白呢始终大概就是控制在这个3 gram 以内。那到比较最近哈的这个一次门诊，我们可以看到它eGFR还是 maintain 在几乎原来的这个位置哈。那后来的习惯我们改成用 UACR， 那就发现说这个病人 UACR 大概还是超过2000了哈。那所以接下来就是说，到底这个病人我们可能可以再给他加上什么辅助的治疗哈？那当然在接下来任何这个可能对肾脏保护有帮忙药物，大概就是要用自费了哈。那另外就是说，这个病人他eGFR已经小于25，那你如果要用这个，不管是 finerenone 还是 semaglutide， 应该都是 off label 了哈。如果根据这个 semaglutide 之前的 flow 的 try 跟 finerenone 之前，不管是心血管还是这个 CKD 的这个 try 哈，那你要用这2个药物，就可能需要跟病人做一个比较详细的一个解释哈。那另外我们可以再看到，就是说，这